As a resident, I have had this doubt and frustration so many times. Why does the AJCC have to keep changing their staging system? Why do we have to keep memorizing the staging systems? Why can't they just leave it at that? The importance is that staging is a very important language for communication amongst oncologists across all specialties. The Masaoka Koga staging system for thymoma was based on a data set of 96 patients. It did have a very important prognostic significance in which patients with stage 3 had a better prognosis than patients with stage 4B without any doubts. But involvement of pericardium was also stage 3, involvement of aorta or brachiocephalic vein was also stage 3, or lung was also stage 3. So when a surgeon in a conference says that they resected a stage 3 thymoma, the others would not understand if they're talking about a pericardial resection or a brachiocephalic vein resection and reconstruction. Granularity was required. So a larger data set was analyzed, 11,000 patients roughly, led to changes in the AJCC 8th edition. So now we know when someone talks about a T2 thymoma, we know they are talking about a thymoma involving one of the relatively easy to resect structures, either a pericardium or lung wedge or a phrenic nerve. Staging is another important language in which adjuvant therapy decisions can be easily made. In the FIGO 2009 staging for endometrial cancer, stage 2 was just involvement of cervical stromal invasion. This was stage 2 endometrial cancer. Now, a lot of trials evaluating the role of adjuvant therapy in endometrial cancer led to this conclusion, grouping of these three: cervical stromal invasion, that is stage 2 endometrial cancer, or a stage 1 endometrial cancer with substantial LVSI, or a more than 50% myometrial invasion endometrial cancer with a high grade histology. So, all these three were placed together in the same risk group, the same prognostic risk group of high intermediate risk, which require a similar or a same adjuvant therapy. So, when FIGO 2023 was introduced, by logic, all these three were simply just put into the same group. So now we don't have to say stage 2 or stage 1 with substantial LVSI or stage 1B with high grade. All this is HIR. We need to give this adjuvant. We don't have to talk all these details. We just have to say stage 2 FIGO 2023 requires this adjuvant because all of these three have been put together in the same risk group. This made things very simple. Another very important and interesting example to understand. So, wisdom accumulated before 2000s for lung cancer, tumors less than 3 centimeters, adjuvant therapy was not required. Tumors more than 5 centimeters, adjuvant systemic was definitely required. Now, the question was, what about these tumors that are between 3 to 5 centimeters? There was no answer. So, someone tried to answer this question in a randomized control trial, and they found out that tumors between 3 to 4 centimeters had no benefit with adjuvant systemic, whereas tumors that were 4 to 5 centimeters had a significant benefit with adjuvant systemic. Published in 2008, IASLC Phase 2 analysis of data accumulated between 2000 to 2010 and the patients treated between 2000 and 2010 all over the world, leading to changes in the 8th edition of AJCC in 2017, where the group, which was a single group, 3 to 5 centimeters, now is divided into two. 3 to 4 centimeters is T2A, and they do not need adjuvant systemic therapy, whereas 4 to 5 centimeters is T2B, making it stage 2A. All stage 2 will need, we can just now say all stage 2 will require adjuvant systemic therapy. So, oncology is actually an infant, which is all of us are continuously learning with accumulation of new data and new evidence. So, all these changes are expected to happen at an even more rapid pace because of the rapid accumulation of data. And this is rather an interesting